I'm actually, although we didn't really consult beforehand, I'm going to follow seamlessly on from the last two talks. And my talk is going to be, the first little bit of it is just going to be optimistic. And it's going to be optimistic because the problems that have been outlined are soluble, and in my view, in the majority of cases, they are soluble in our generation. But they're only soluble if we actually bring together all the different sciences to bear to actually make them work. From the most basic molecular sciences, the most basic bench sciences, all the way through to the most applied and social science skills. Why should we actually do this? Well, I'm going to take a slightly different take on this. This is the world as it was roughly the time that Jimmy was born. There. At that point, Europe was substantially more populous than Africa. Europe in blue, Africa in orange. By the time we get to the end of this century, over a third of the world's population will live in Africa. 45% will live in Asia. Europe will have less than 8% of the population. North America, even less than that. This is where the battle for health for humanity is going to be fought and won or lost, just on the numbers. So I think that would be my first general point. And when one of the privileges of being a senior civil servant is I get to see what the media are saying every single day about international development. And I don't think it's any secret that some members of the press don't particularly like the fact that all the political parties have taken the incredibly brave decision to put 0.7% of UK's GNI behind international development. My view is if you look at this, you ask yourself, well, why not? Going on to the next two slides, I've shamelessly stolen from Hans Rosling, and I've stolen them because they're so good, and I can't. It feeds into a slide that Jimmy showed. This is the world in 1800. And at that point, there was huge convergence in health. This is every country in the world plotted. And at that point, the richest country in the world actually had a mortality rate of around 40. Sorry, the average age at which people would die was around 40. What has happened in the subsequent 2 centuries is that we've moved from a situation where that was the case to one where almost all the countries in the world are lined up. These are logarithmic scales, which is why it doesn't look quite the same as Jimmy's, but it's roughly the same thing. This is every country in the world, but where we're getting a grand convergence at somewhere between 75 and 85. And all countries in the world, as they develop, will move up this line to around about here. They may carry on going, but I think most people think that is roughly where they're going to stop. Our job, I think, in our generation is to get all of the countries down here up as far as we can to the convergence, instead of down here, right up here. Now, just 2 points in addition on this. The first is all the countries in dark blue are in Africa. All the countries in light blue are in South Central Asia. Again, these are the countries where we can do something. And in general terms, getting countries from around about here to around about here is about getting on top of infectious diseases. After that, there are large improvements you're going to need elsewhere, but that is probably where the majority of this early shift upwards is going to happen. The second point I'd like to make is that if I'd chosen a slide in between whiles and looked at the UK at the height of empire, in 1900, at the point when the UK was easily the most powerful and wealthy country in the world, its mortality was around about here, below Rwanda, as it is now. Most countries, even that we currently consider poor, have a better health at this point in time than we had at the point we were the most powerful country in the world. And again, it's important to understand that when actually realizing this is an optimistic picture. That does not say that we haven't had some setbacks. And I'm showing here some UK data because this was a time, I came back from working in Thailand on HIV and amyloidosis, a rare disease, to work here in Brighton in 1994. In 1994, we were at the point where the HIV death rates in the UK were peaking, and Brighton was at the centre of that because of its population structure. I watched many men of my age at that stage dying, completely irreversible. There was no way we could reverse their illness at that point because we did not have any of the drugs we needed to actually treat them. So this is actually easily, in my own professional lifetime here in Brighton, this was a disease we could do nothing about. Of course, since then, because of antiretrovirals and a variety of other things, that has been reversed. Most people with HIV in the UK will now live a completely normal life, at least into their 60s. Beyond that, I think we don't yet know. But the continent clearly, which bore the brunt of this, was Africa. Africa was where HIV started, probably in DRC and in West Africa at least two different occasions, and spread remarkably fast to 1999. So I was subsequently had the privilege to work in Malawi alongside colleagues from the Wellcome Trust, although I wasn't working for them. At the point I was working there, a third of women my age had HIV. All of them pretty well will have gone on to die. So that was a situation only 1.5 decades ago in Africa. And yet actually if we look at HIV now, a disease that is a relatively new disease which has provided enormous impact on the world, it's in retreat, including in Africa, in full retreat in my view. The incidence of the disease is dropping, the death rates from those who actually have HIV is dropping around the world. At this point in time, the great majority of people with HIV should not be dying because we have the ways to deal with that. How did that happen? Well, it happened because of development, but it also happened absolutely critically because of science. And I'm just listing out here some of the sciences that have been central to making this happen. Epidemiology, the actual mapping this out, working out what the transmission is, working out where it's coming from. Obviously clinical sciences, immunology and physiology, which help form the scientific base, along with the virology, for then the pharmacology, which helped to develop the drugs. Clearly manufacturing issues. These were not easy drugs to deal with. Mathematical modelling and the ways we actually tried to work out how you best impacted. Still developing in my view. Some of the current models I consider are wrong, but we are improving in this. But then also moving firmly into the social sciences, the anthropology, the economics, the marketing, and I put in brackets the political science. The reason I put that in brackets is political science should have been central to this debate, but actually has played a remarkably little role. And that, I think, is pretty shameful on the political science community, because what we know is that there is a very clear difference between those countries where the politics was got right. Northern Thailand, for example, where I was, turned the tide almost completely due to politics, and the countries where we got it wrong. South Africa would be a very good example of that. Political science commentary on this has unfortunately been of academic but not practical use. So there are huge numbers of sciences from all the disciplines which should be essential in attacking this disease as many others. Because of that, we have seen a gradual decrease, as Jimmy was saying, in mortality. Childhood death is a reasonably good proxy across every single area of disease you can think of, particularly on the infectious diseases. And this has been true worldwide. Until relatively recently, Africa had actually got stuck. But that's not the case now. And I particularly like this headline from The Economist from 2012. Africa, and this is true, Africa is experiencing some of the biggest falls in child mortality ever seen anywhere. That is the situation we have at the moment. It's an extraordinarily hopeful one. And if you look at many of the countries where the biggest falls are occurring, some of them are the countries you'd expect. Some of the countries like Ethiopia, which are involved in this area, but there are many countries where things are falling rapidly, like, for example, Benin or Nigeria, where if you read the press, you would think that we were actually going nowhere. So across the continent, with a few exceptions, and those are largely ones which you would predict, mortality is falling extremely rapidly. Now, what has been the basis for this? Well, I think this would be my second very broad point. If you look at this is a nice study done looking at what the likelihood of countries getting to the Millennium Development Goals that Jimmy talked about. And the point with this, there are 2 points I'd like to make. First of all, this is from Niger. Niger is not a country which I would consider has got good governance and all the things running for it. This is a country that has got a whole series of problems which I think anyone who reads the newspapers in terms of the foreign pages will be well aware of. And the point I'd like to make on this is this reduction is made up of a whole series of individual steps, insecticide-treated nets, improvements in nutritional status, vitamin, etc., going down. And the list could actually have gone down. If I took any one of those, there are multiple scientific steps that have allowed those improvements to happen, from the most basic to the most applied and in through to the social sciences. Every single one of those big improvements is based on scientific improvements, many of which the UK through funding from the Wellcome Trust, through other things, has contributed to very strongly. And every one of these, actually, the UK has played a major role in helping to unravel the science from the most basic through to the most applied. I think it's something which we as a country, I think, can feel collectively proud of. Moving on to a disease which I've spent quite a bit of time, just taking malaria. Malaria mortality is dropping extremely rapidly. It's probably gone down by 30% in the last 10 years. This is a disease which still has an extremely poor toll, but definitely, as you can see, the trend is in the right direction. And that's, of course, on the background of very major advances in malaria, again, which the UK has played a very large part in getting us from this picture, which is 1900, malaria really quite widely distributed with substantial malaria in different places, to the picture we have now. If you look at the map of malaria, it looks, if you just say, have you got malaria or not got malaria, the map looks remarkably static. If you look at where it's gone down everywhere. And this map here just highlights in particular the areas where the drop has been fastest. Now, one of the biggest tools for this, and one I think even people in the general public are relatively aware of, are insecticide-treated bed nets. Just think about this technology, which looks so simple. The first thing it depended on was unravelling the transmission mechanisms of malaria, for which Ross got the second Nobel Prize for Medicine. A lot of the epidemiology behind that, where do the mosquitoes live? A lot of entomological studies had to go on that. Then you had to have a whole variety of studies which actually did mathematical modelling, the Ross-McDonald model in particular, which actually demonstrated which things would have the greatest impact on transmission. And they're not the things you'd expect. Killing mosquitoes, for example, is not a very effective way to actually get malaria down. You have to have people who are doing different sciences to actually produce the chemicals which actually are insecticidal, and you have to then have the toxicology to make sure that the child, when it sucks the net, is not going to have some serious problem as a result of it. You've got to have manufacturing skills which can actually make these nets durable, and more recently have made them long-lasting so you can weave the insecticides in. But you also then have to have social sciences to work out how to get them to people, to work out all the various steps there are between someone deciding to buy a net and to use a net. So, for example, in some countries, if you use a white net, people will not use it because it's a colour of death. In some countries, people don't like see-through nets, they want opaque nets. These kinds of things are just as important as the basic science that got us there in the first place. So every single science, really, will have contributed to what most people would think of as an incredibly simple intervention for one disease. And this I could repeat over and over again. I'm just taking that as an illustration. There are, of course, many deaths, and in Africa, at the moment, the great majority do remain in two groups, the infectious diseases and, as Jimmy said, the neonatal deaths. And the neonatal deaths are getting remarkably stuck at the moment compared to others. They are dropping, but nowhere near the rate of other things. And if we look at Asia, compared to Africa, the ones in yellow are the neonatal deaths. I'll go back to Africa. What you can see is as time goes by, as we got on top of infectious diseases, the neonatal deaths have moved to a situation in South Asia where they now make up over half of all the childhood deaths that exist. Basically, your chance of dying in the first 28 days in Asia is greater than your chance of dying for the rest of your childhood. This is a serious issue, and one I think where particularly the social sciences have a major role to play. So that's the situation at the moment. Now I'm going to go on, following on from Jimmy, to do, and this bit, and so what I've said so far in a sense is uncontroversial. I don't think many people disagree with it. People may or may not disagree with what I'm about to say, but I'm going to give my own crystal ball as to what the scientists that this centre are going to be training are going to be grappling with in 20 to 30 years' time. And some of these changes are, I think, relatively easy to predict. This is a potentially slightly optimistic demographic profile for Ethiopia, one of the countries that is involved in this centre, central to this centre, comparing where it was in 1950, this sort of rather skinny thing here, 2010 where we are now. But I'd like you to look at this bottom bit. The classic population pyramid for developing countries is a population pyramid that goes up like this, where almost everyone is young children, very young children, under the age of 5. Ethiopia has started to have a situation where its population is stabilising, so that by 2050 there is a realistic chance that Ethiopia will have a population that looks like this. Now that has two implications. One is a very important potential economic one, that the portion of the population in the working age compared to the very young children and the elderly, basically the dependency ratio will be extremely favourable for Ethiopia. And this will be true for many other countries. Now, this depends on many other things happening, particularly including women's health being maintained and contraception being available. But that is the direction of travel. But the second one is the proportion. When most people think of developing world, they almost always concentrate on young children. And actually, as the population moves from a pyramid like this to a pyramid like this, the great majority of the poor will no longer be young children, they will be adults. And I think this shift towards adulthood as where most poor people will have their health, I think has not fully been internalised in people who are doing planning. India, for example, another country with a lot of poverty, it's already going through its transition extremely rapidly. So we're already in the situation, in 20 years' time, the great majority of Indians who are poor will be adults. That is a certainty. In Ethiopia, it's a probability. Unfortunately, there are some countries where this is not happening. Nigeria. There's still a situation in many parts of the north of Nigeria, for example, where the median woman has 7 children who survive. That is seriously bad for her, it's bad for her family, and it is a major health challenge. So in some places, childhood is where the big problems, childhood and pregnancy, are where the big problems will arise. But in many countries, this is changing extremely rapidly. And of course, there are some countries that have really weird demographics. I'm choosing South Africa. This is the effect of HIV. And the social implications of this are, I think, something which are fairly obvious just by looking at the graphs. So that's the first, and the demographic changes, I think, have, as I say, not always been fully understood by people who are making planning. The second big trend is urbanisation. Already, probably most poor people in Asia are in cities, and by the time we get to 2040, it is probable that most poor people in Africa will be in cities. So we'll move from a situation where the classic developing world person is a child in a rural environment to one where the classic poor person will be an adult in an urban environment. That has huge implications for their risk factors and for what we can do about it. And again, I think we need to think these through. Hopefully, some of our old enemies will be gone. Guinea worm is probably going to be the third disease to be eradicated. The first being smallpox and the second being rinderpest in cattle. If we're lucky, we'll get rid of polio in the next 10 years, but that's all worth an entire 45 minutes in its own right. And crucially, for both of these diseases, the problem is not medical or epidemiological. We know what to do here. The problem is going to be to do with the political and social sciences. That's really where the sciences have got something to offer, and I think have possibly been underplayed. That's not the fault of the sciences, it's the fault of the policymakers, I think, have not been concentrating on these enough. Moving on to the neglected tropical diseases, good news is that neglected tropical diseases are surprisingly unneglected these days. They're still called neglected tropical diseases, but in fact the proportion of money that goes into them compared to their disease burden is, I think, now stabilising to a much more reasonable level. I would now say the neglected tropical diseases probably are things like pneumonia and diarrhoea in terms of spend compared to mortality. In most of these, I've chosen to illustrate them with 6 of them. There have been significant forward progress in the last 10 years, both in science but also importantly in disease incidence. Lower, this is a West African problem. Trachoma, I don't think we're going to eradicate it, but we'll get it down to very low levels, I think, very soon. Very good, very simple science based on this, which mass treatment with antibiotics. This is mass treatment with drugs. Human African trypanosomiasis, beginning to go away because it's primarily a disease of conflict, actually. Not seen as that, but that's the reality. So it's mainly only in conflict areas now. But unfortunately, Sudan, one of the countries in your centre, is one of the few places which still has a substantial human African trypanosomiasis burden. Leprosy, going but not gone. And there are countries like India and Brazil where leprosy incidence rates are stubbornly flat. So it's gone away in much of Africa, but not in its heartlands. Filariasis, yaws, a disease, or a skin disease very similar to syphilis. These diseases, all of them, are actually in retreat, not necessarily in full retreat, but every year they're going backwards. The proportion of disease that they're going to mean to be in 20 years' time will be much smaller than what it is now, provided we just hold our nerves steady. And what that means, and part of the reason for that, is we actually have the tools for most of these diseases now. Let us say 10 years ago, human African trypanosomiasis, the only drug that was available, killed 5% of the people you gave it to. It was based on arsenic. it's now a great deal safer. So the tools are getting a lot better. What that means is we're moving from a situation where the problem is we didn't have tools at all to ones where we have the tools but we're not delivering to the right people. And I'm just illustrating this. You have something that's 97% efficacious, but then only 60% of people actually attend a health centre or any kind of healthcare at all. They get a diagnosis in maybe half the cases. Only 20% of them are given an effective drug. Taken correctly, well, 90% of them take that. But by the time you get down to the bottom here, that 97% effective drug has actually had a 5% impact on the population. Getting this right is actually the key to a lot of the health problems that we now have remaining. And one thing that's not going well, antimicrobial resistance, a point which our current Chief Medical Officer, Dame Sally Davis, has made a big push on, something which I think the Wellcome Trust is very interested in. There is now significant resistance to most of the cheap antibiotics, most of the cheap anti-tuberculous drugs, to most of the first-line antiviral drugs, particularly HIV drugs. Very rapid resistance that develops to flu drugs, and flu is the big risk in terms of epidemics generally. And malaria, for example, significant anti-malarial resistance now developing in Southeast Asia. So there are many areas where we're going forward, but there are some areas where we're going back. And these are driven, the solution to this is partly to develop new drugs, but it's also to get around the social problems of adherence, poor diagnostic practice, and all of these kind of things. I think people think far too much about throwing millions of pounds into, billions of pounds actually, in developing new drugs, and possibly could throw a bit more into actually how we actually stop the drivers in the first place. Because if you stop the drivers, very often the disease actually retreats. MRSA, just take a UK example, MRSA used to be a huge problem where the Daily Mail used to have at least a session a week on it. It's now down to a session every 2 or 3 months because actually the amount of MRSA has dropped a long way down, and that's nothing to do with technology, that's just we worked out how to get people to wash their hands. Many of these things have interventions which are as simple as that. Now, Jimmy mentioned the rise of non-chemical diseases, and this clearly is going to happen. As infectious diseases go down, other non-chemical diseases are clearly going to become a much greater proportion of disease. The question I would like to pose, and this is the one, in a sense, semi-controversial point I'm making, is a very appealing and completely incorrect syllogism is currently being used across funders for non-communicable diseases in health. And the syllogism goes on like this. The majority of people who are poor now live in middle-income countries. You heard Jimmy say that. Correct statement. The majority of people who have, let's say, diabetes live in, let's say, India. Correct statement. Therefore, the majority of poor people, well, we need to deal with diabetes because it's a disease of poverty. Not true. That's a false syllogism. There are many non-communicable diseases which are the diseases of the poor, but the great majority of the cancers, the circulation diseases, diabetes and so on, are actually diseases of the middle classes. They are poorer countries, but they're actually richer people. What will kill you if you're a very poor child in Calcutta is never going to be diabetes, virtually. It's going to be the old diseases of poverty. But there are some very important non-communicable diseases of poverty, and I think we haven't yet properly, as a community, thought through seriously which are the non-communicable diseases of poverty. We know what the non-communicable diseases are. A few of them are obvious. I couldn't not mention podocarditis because Gail would kill me afterwards if I didn't, but clearly podocarditis is a non-communicable disease of poverty. Is smoking a non-communicable disease of poverty? Actually, partially is the answer. There is a slight tendency for it to be down at the bottom end of the social spectrum, but that depends on whether you're male or female. If you're a poor woman, it is not a problem. If you're a poor man, it is a problem. I'm making huge generalizations. So there are complexities to these. There are other diseases like arsenicosis, which I've identified here. A problem of poverty in some situations, in Bangladesh, for example, because people don't have proper boreholes. In other areas, it's people who actually work in quite high-profile industries like mining, where they're well paid. It may not be a disease of poverty. So I think that the complexities of these kinds of things, and of course, whether a disease is a disease of poverty or not, there may also be problems that poor people have a disease that isn't a disease of poverty, but they can't access healthcare. So you might have type 1 diabetes, but the reason why poor people die of type 1 diabetes is because they just can't get to doctors. So there are health systems problems, even if the disease itself is not a disease of poverty. But I think we don't think subtly enough in my view, about what are the diseases, the non-communicable diseases we should be concentrating on. It's not the same ones as we should be concentrating on here, and yet I think that rather easy progression has happened in a lot of thinking amongst funders in the UK. And finally, genetics. I couldn't not mention that, given the interest of this, but it is a very important issue. If you look at many countries in the world, they have what I would call the genetic memory of the past. There are a number of genetic conditions which are there because a particular genetic predisposition has helped them in the past, but is now going to cause them problems in the future. I happen to illustrate this as G6PD deficiency, which is an enzyme deficiency which is very rare in countries where there's never been malaria and very common in countries where there has. Same as sickle, same as thalassemia. Malaria, for example, has driven a very large amount of genetic disease because certain genetic things protect you against malaria. But when the malaria has gone away, this turns from a mild benefit into a distinct disadvantage. But this would also be true in many of the things, for example, the metabolic syndromes. I actually started off my research career looking at the ethnic differences in UK people of African origin, South Asian origin, Southeast Asian origin, and white origin. And they have totally different risk factors biologically, biochemically, for heart attacks, strokes, and so on. There are some cultural and behavioural issues as well. So, as Melanie was saying at the beginning of her talk, some of the problems that these countries are going to face as they move out of a situation where infections are the big problem are going to be driven by their genes. And in many cases, we don't know which. So getting this kind of skill set available in Africa and Asia is clearly going to be essential. Final slide, just a few points on the centre as someone who doesn't either fund it or work in it. First point, genetics of major disease is very important, and I think that last slide I hope sort of reinforced that issue. But I cannot say how strongly this issue about building capacity for health research in Africa is going to be over the next 20 years. If all of the research that is there to solve the problems for a third of the world's population is supposed to come out of the UK in 80 years' time, that's going to be a very serious problem. But it is important to understand that there are at least three things you need to do if you want to take research capacity strengthening seriously. The first of which is you have to view it as a very, very long-term bet. 20, 30-year time horizons is what you need. If you think about it, the time that it takes to get someone from a bright child in primary school through to being an independent researcher, and every single step along the way, there is a problem with education in most of the countries we're interested in. There are many ways that things can fall off. You've got to take a very long horizon. You've got to think about the entire educational system, which is my second point, rather than just focusing only on the people at the top. The people at the top is very much an important thing that people in institutions like this can do, but the rest of us do also have to think about all the other stages that can be there and on the way. The second is, it's really critical to focus on incredibly good individuals, and that's what this centre will do, but you have to also strengthen the institutions into which they go. A brilliant scientist in a useless institution will never be able to hold a grant because they'll not be able to manage it. They'll never have people around them who can actually help them. They won't have the postdoctoral and other people supporting them. Essentially, they're isolated. So you've got to build up the institution, and of course you've also got to build up the infrastructure around it. You've got to have things like proper ethics committees that are local, because ethics is a cultural issue. What is ethically acceptable in the UK, perfectly rightly, is different in both positive and negative ways than what is ethically acceptable elsewhere. We can't just rely on our ethics, for example, to actually help elsewhere. So these ancillary things of building up ability to handle grants, dealing with ethics, all these kind of things are as important as building up individuals. That is critical. Without good individuals, everything else falls, but the good individuals cannot operate in isolation. But I think my general point, at the launch of a new centre, and I share Jimmy's admiration for Brighton having managed to get themselves from 10 years to this position, the ability of institutions like this to have a phenomenal impact in the next 20 years, I think is virtually unbounded. If you look at what has happened in the diseases we've chosen to take a real swing at, it has been transformed in the last 20 years. And there's no reason why that transformation cannot continue, provided we continue to invest in it, provided we continue to have the brightest minds going into it, and provided we use every single one of the sciences rather than concentrating just on a few of them in isolation, because that way disaster lies. But I think the outlook, to be frank, is extraordinarily bright for this centre and for global health altogether. Thank you very much.